Good evening, everyone. Welcome to Master Classes in Critical Care Medicine from Yashoda Hospitals in association with ISC Hyderabad chapter. So today's case discussion is on acute pyelonephritis, acute kidney injury, and renal replacement therapy. We have
Dr. Kanwal, you can continue, ma'am.
Sorry, there were some technical hitches. So we just start with today's master class, and it's basically about the acute kidney injury and renal replacement therapy. So we'll have a detailed discussion. We have with us Dr. Subhal Dixit. He is the past president ISCCM and a renowned teacher. So I think he'll be joining in another 1 or 2 minutes. And
I am actually joined here. I'm just.
Hi, sir. Good evening.
Good evening. Good
okay,
evening.
welcome, sir. So
yeah, good evening.
I think the students will be enriched most by your presence. So, and I'm there for all of you. And we have 2 students, Dr. Dinesh Kumar G and Dr. Shravani. So they'll be presenting the case. I think, Subhal, sir, can we?
Yeah, I can listen. You can start.
Okay. Thank you. So Dr. Dinesh, over to you.
Yes, sir. Can I share the screen now?
Yes, sir.
Sir, is it visible, sir?
Yes, it's visible. Make it full screen.
Yes, sir. Yes, sir. Sir, is it visible, sir?
Yes, good to go.
Okay. Good evening, everyone. Myself, Dr. Dinesh. I'm a final year critical care resident doing at Acute Hospitals, Hyderabad. So today, our case of presentation, I'm going to present on acute pyelonephritis patient. So here is a 64-year-old retired postman who presented to us a few weeks ago with complaints of fever with right side flank pain for 4 days duration, and there is history of decreased urine output for 2 days duration. Coming to his history of present illness, he had fever since 4 days, which was associated with chills and dryness, and it was relieved with medication. And he had fever was associated with the right side flank pain, which was sudden in onset and was gradually progressive, associated with vomiting, which was non-projectile and non-bilious. And there were no aggravating and relieving factors, and the pain was non-radiating in nature. And for the pain, he has been taking, he has taken 4 doses of tablet diclofenac, and following which he had a decreased urine output for 2 days associated with dysuria and increased urinary frequency and urgency to void. And a day before, he presented to us with the history of SOB, which was insidious in onset, was initially of grade 2 and was progressed to grade 3 on presentation to ER. This was this history of presenting illness, and negative history. There was no history of any rash, jaundice, loose stools, or headache, and there was no history of any chest pain, palpitations, facial puffiness, or pedal edema.
Yeah, Dr. Sodhi, you can take from here, I think.
Okay.
My question is, why specifically have you mentioned about projectile vomiting and non-bilious vomiting?
Sir, yes, sir. I would like to rule out any obstructive causes of intestinal obstructive causes as the presenting complaint, sir. So, as it was non-bilious and.
But it's coming with a very frank right-sided flank pain.
Yes, sir.
Intestinal obstruction will have epigastric pain or a quadrant pain. A flank is usually a quite different kind and specifically points down to a renal angle, possible tenderness,
yes,
kind of thing.
So that like main of intestinal obstruction causes.
And especially if it's taken for a gastritis and all, it's not going to be projectile, or means it's taken diclofenac.
Yes, sir.
Really speaking, from the exam point of view, fine, but from the critical care angle and a super specialty exam, that's I won't give that much importance for it. But more important is the right side flank pain and fever with chills.
Yes, sir.
Associated with decreased urine output and shortness of breath.
Thanks.
Okay.
Yes, sir.
Okay. How do you classify shortness of breath? Well, you have said that it went from from grade 1 to grade 3.
Yes, sir. The
which kind of classification? Which kind? Have you used the NYHA classification here or which classification?
MMRC classification, sir.
Pardon?
MMRC classification, Modified Medical Research Council classification, okay. Where grade 1 usually patient present complaints only of SOB only on strenuous exercises. Grade 2, the patient will not be able to compete with contemporaries. Grade 3, block limitation. Grade 4, usually on rest, the patient will be complaining of SOB.
Any other sign symptoms you can just look at for this?
Symptoms, history, apart from the fever and right side, cause of SOB, ma'am, I just wanted to rule out, is it associated with any cough or any history of SOB? Is it associated with pedal edema or PND history, orthopnea history? I just wanted to rule out any cardiac association as a possible etiology in presentation. Cardiac cause as a precipitating of existing etiology. I just wanted to rule out cardiac source. So there was no PND history or orthopnea history, ma'am. He had only SOB, which was associated with the dry cough only, ma'am, not any productive cough. And
any other symptomatology specifically points to the urinary tract infection, like
mainly of supra. The patient will be complaining of mainly if it lower urinary tract symptoms, mainly of dysuria, increased frequency, urgency, and suprapubic pain, the right-sided flank pain. If it's stone related, the pain can be radiating to the back or to the testis. Radiating kind of pain, and apart from that, usually associated with vomitings also.
Vomiting you have already highlighted.
Fever,
can be some bilateral costovertebral pain can also happen.
Yes, ma'am. Bilateral cost, yes, ma'am.
And then the altered mental status.
Yeah, altered mental status. Yeah, that is also presentation.
Right. So elderly man, and you can with UTI you can have a right.
Yes, ma'am.
So okay. So we move ahead, or like now your provisional diagnosis?
Based on the history, I'm suspecting an urinary tract infection, ma'am. As is an 64-year elderly male, I'm suspecting a complicated urinary tract infection in him, ma'am.
Why do you say specifically complicated urinary tract?
Urinary tract infection associated in male is a complicated urinary tract infection, ma'am. Any UTI in males is a complicated UTI, ma'am. That's why I'm.
What is a simple UTI?
Simple UTI patient just presents it with history of, if it is not associated with any anatomical structural abnormalities and there are no high risk factors, it's a simple UTI where patient presents only with history of fever, dysuria, increased frequency and urgency. There are no anatomical structural functional abnormalities as such to tell the patient is having a complicated simple UTI is that presentation.
Dinesh, can you tell me the differential diagnosis of this patient? Have you thought any differential diagnosis?
Differential, sir. My main first provisional diagnosis is a complicated UTI, sir, as already told. And a second differential diagnosis in him, I would like to rule out nephrolithiasis, sir. And third thing, I would like to rule out.
Hello, Dinesh. Nephrolithiasis is a working clinical diagnosis. It is a nephrolithiasis. Can you touch the abdomen and tell that this is he's got renal calculus? Nephrolithiasis is a sonographic diagnosis.
Yes, but pain, any radiating pain, usually.
Radiating pain, it could be, you can say a renal colic. You have said pyelonephritis, it could be a renal colic. You can't say nephrolithiasis as a working diagnosis. That is a part of the diagnosis. You tell me the working, it's like appendicitis, acute pancreatitis, acute colitis, or can it be a Crohn's, which has also, Crohn's can also have such kind of infections and have fever.
Yes, sir. So other differential diagnoses are any acute hepatitis or cholecystitis, pancreatitis, or appendicitis. Sir. This will be like 2, 3, 4, 5 causes differential diagnosis.
Okay, how will you distinguish them?
Yes, sir. History-wise, if it is hepatitis or cholecystitis, I would like to ask any history of outside food intake, sir. Mainly the hepatitis A and E associated with fecal-oral contamination, and any history of jaundice also, sir. Usually, the hepatitis and cholecystitis is more of jaundice, generalized weakness, malaise, decreased food intake, loss of appetite. All these more will point out in favor of any history of ethanol consumption. More common, sir, like. In those population, hepatitis and cholecystitis based on that history.
Okay. Yeah, Kanwal.
So you can just, I can think we can move ahead.
Yeah.
So coming to his past and personal history, sir, he was a known diabetic for the past 4 years, sir. And currently he's on injection human mixed. He was taking 30 and 25 units in the morning and the night, and tablets sitagliptin and metformin, PD dosage. He had recent dose adjustment done for his insulin dosing, sir, because his HbA1c, which was done a month ago, it was around 9.5. He has consulted his local physician and he has done this dose adjustment. And there is history of peripheral neuropathy, and he was on tablet pregabalin. OD dose, and there was history of cataract surgery for the both eyes 5 years ago, and he is a known hypertensive since 4 years, and he was on tablet telmisartan 40 mg. Personal history is having normal bowel habits and normal appetite. He consumes a mixed diet, and he is a non-smoker and non-ethanolic.
Yeah, go on.
Yes, sir. So coming to his physical examination, sir, his patient was conscious, coherent, and obeying commands. There was no pallor-ictus, cyanosis, clubbing, or lymphadenopathy or edema. His heart rate was 130, he was tachycardic. Blood pressures were 130/80 millimeters of mercury, and respiratory rate was slightly tachypneic, sir, respiratory of 28, and he was saturating of 96% at room air, and his temperature was 101 on presentation to ER, and blood sugars were 194 on presentation to ER. Systemic examination, he was having parabdomen findings. It was sought with tenderness, noted it in the right lumbar region. Sir.
Okay. Yeah, go on.
Based on the history and presentation, presentation and clinical examination, sir, my first provisional diagnosis is a complicated UTI, likely pyelonephritis, sir, is my first differential diagnosis. Second and third, I would like to rule out that acute abdominal causes like hepatitis, cholecystitis, along with that appendicitis also I would like to rule out, sir. And still I would like to rule out a possibility of tropical infections being associated in him, sir. Tropical infections being associated. That would be also one of my differential diagnoses.
What tropical infections? What tropical infections can you think of?
Sir, scrub typhus, leptospirosis, malaria, dengue, even dengue, complicated dengue, expanded dengue also can present.
A complicated dengue will have abdominal pain, but not that much amount of dysuria.
Dysuria.
Will come in with joint pains.
Yes,
leptospirosis will come in with decreased urine output, but now that when the symptom wise there will be certain amount of the chills, fever that way. Scrub typhus will again present in a separate way. Malaria will not present in in this way. Dengue is only, but dengue hemorrhagic, if you think, then okay, there will be abdominal distension, there will be hepatitis, but there will be rashes and decreased urine output. But it doesn't fit into a tropical kind of thing. Na?
Okay, sir. Yes, mainly acute abdominal.
So it's acute abdomen, possibly a focus,
yes,
genitourinary focus in a diabetic who is uncontrolled with 190 odd sugars. What was the HbA1c?
9.5, sir. A month ago it was done, sir. 9.5.
Okay. So it's a typical kind of a situation which is commonly seen, and your working diagnosis is AKI with AKI, acute kidney injury, oliguria. How will you define oliguria, anuria?
Sir, oliguria, if the urine output is less than 0.5 ml per kg per hour, sir, or urine output less than 500 ml per 24 hours. Anuria, if the urine output is less than 50 ml or 24 hours. Yes.
Okay. Yeah, go on.
And how do you define acute kidney injury?
Sir, the conventional definition of acute kidney injury is an abrupt decrease in the GFR happened over hours to minutes to days, up to 7 days, which is associated with elevation of blood urea, nitrogen, and creatinine levels. As per the KDIGO, definition guidelines, creatinine absolute rise by 0.3 happened within 48 hours, or 1.5 to 1.9 times rise from the baseline presumed to be happened within the past 7 days, or urine output less than 0.5 ml per kg per hour over 6 hours. 6 hours. I'd like to say that as patient would like have AKI as per KDIGO definition.
You have written, you have a oliguric AKI.
Yes, ma'am. Yes, ma'am. Oliguric AKI.
Do you actually mention always in the diagnosis that it's an oliguric AKI?
No, ma'am. Actually, this was a provisional diagnosis. Prior to that, any patient, I would like to, before comment oliguria, I would like to do a point of care ultrasound. As it a male, elderly male, I would like to rule out obstructive causes of oliguria, ma'am. And then only I would like to comment whether the patient is having oliguria, ma'am. So first thing I would like to do is a point of care ultrasound, rule out any obstructive causes where even a simple Foley's catheterization might relieve this obstruction.
And purely retention of urine.
Yes, yes, ma'am. Retention of urine. So prior to that, I would like to rule out and then only comment on oliguria. So yes, ma'am.
Okay, so now that you have a working diagnosis,
Yes, sir.
how will you evaluate this patient?
So as I'm suspecting complicated UTI, likely pyelonephritis, sir. So I would like to send investigations which are indicated, sir. So I would like to send a complete bed picture. In that I would like to look for any elevated in total TLC leukocytes associated with any neutrophilic predominance or not. And then I would like to see any thrombocytopenia, any associated renal function test to see the grade of AKI and electrolytes, any electrolyte abnormality. Liver function test, I would like to see either any extra renal involvement happened or not. And along with that, I would like to send urine cultures and blood cultures, sir. And on presentation to here, I would like to do an ABG of this patient, so to see for any acid-base abnormalities and any blood gas and abnormality associated. So these are the set of CBC, LFT, RFT, then urine cultures, blood cultures, and ABG. As he presented in a SOB, I would like to do even a chest X-ray. Chest X-ray.
ECG?
Any other basic?
ECG, yes. I'm sorry, ECG, sir. 12 ECG, I would like to get definitely.
Anything else?
Ultrasound?
Yes, sir. Ultrasound abdomen. Like first thing I would like to rule out is an obstruction. So ultrasound abdomen also I would like to do to first rule out obstructive causes of oliguria.
Okay, will you like to do only
urine routine?
And
microscopy?
Urine
routine.
Yes, sir.
Urine
Definitely.
routine.
Definitely CUE I would like to send them along
Any
with
specific test? Any specific test would you like to do on a urine routine?
Yes.
Sir, I would like to look for the nitrite and leukocyte estrase test and pus cells, not specific, sir, but leukocyte estrase test and nitrite test
What
combined.
nitrite test?
Sir,
what does it indicate?
Presence of bacteria, sir. Presence of bacteria will convert the nitrate to nitrite, so then it will come positive. Or any urea splitting organisms in the urine also is.
Again, it was more in favor of E. coli.
Yes, sir. Urea splitting.
E.
coli, sir. Yes, sir.
Would you like to do acetone in this patient?
Acetone, definitely, sir, because it's an he's uncontrolled diabetic. I would like to see whether DK has been precipitated because of his underlying urinary tract infection. I would like to get, sir. Yes, sir. I would like to.
And what abnormality will you suspect in this patient on the ABT?
Predominantly, if I'm suspecting metabolic acidosis, sir, should be an high anion gap or a combined mixed picture also can be associated, sir. Because patient even presented with history of vomitings, I suspect both the HAGMA and NAGMA combination. And there is a.
You said that he's on metformin.
Yes, sir.
Metformin
Yes, sir.
is also known to induce acidosis if he's taking it for a long period of time.
Yes, sir. Yes, sir. Definitely.
How can you distinguish the acidosis of a sepsis and
sir, yes, sir.
that of metformin?
Sepsis patients might present with associated respiratory alkalosis. Respiratory alkalosis predominantly. The initial presentation can be only an respiratory alkalosis in sepsis patients. As it is advancing compensatory phase, we can see a picture of metabolic acidosis with respiratory alkalosis. Whereas in metformin associated purely, they can present with an high anion gap metabolic acidosis.
Right. Yeah, Kanwal. Yeah.
Yes. I think, sir, we can go ahead. What all investigations?
So these were the set of investigations that we have done on day one, ma'am. His hemoglobin was 12.7. His counts were 25,000. His platelet count were borderline of 1.7. His creatinine was 5.6, ma'am. Bilirubin was slightly elevated, ma'am, with the direct being 1.5. Total was 1.9. Suggestive of direct elevation. Probably could be related to his biliary stasis or with slight elevation of his enzymes. OTPT were 87 and 73. His albumin was 2.5 and INR was 1.37. So,
one question. Can you go back?
Yes, it is.
Just one question. Now that you have just come out of the pandemic, you have been left, right. Would you like to do a CRP and procalcitonin?
Definitely, sir.
IL-6 level in him?
Definitely, I would like to do, sir. I would like to do initially on presentation biomarkers, sir, either a CRP or procalcitonin, sir. I would like to do, sir.
So how would they help you?
Ma'am, it might help for my treatment escalation or de-escalation purpose, ma'am, to see whether the patient is responding to my treatment or not. So procalcitonin might help for the de-escalation purpose to see whether he is responding to my.
Do you use procalcitonin only for de-escalation of antibiotics or what?
prognostication purpose also we can use a bacterial sepsis for yeah, for
on day one you are getting a PCT done. So what purpose it will serve?
So I would like to see that not a single value, ma'am. I would like to see the trend of procalcitonin over the days, ma'am. Like, I would like to repeat it after
Day one,
48.
day one, you have sent it. Day one, the procalcitonin is 3.2.
2.2. Fine, sir. A single value, I would like to see the trend, sir, over next 48, 72
You
hours.
tell me, ma'am. We are telling you, me and Kanwal are telling you is 3.2. What is your interpretation in this case?
Definitely procal is elevated, ma'am. So
you tell me the interpretation and correlation with this case.
As procal is elevated, could be the procal could be secondary to a bacterial infection. The procal could have been elevated, ma'am.
Okay, now he's a diabetic. Okay.
Yes,
if
sir.
He's a diabetic.
Yes, sir.
Will you still think of a fungal UTI in him? He's a diabetic.
Yes, sir. Definitely, sir. But
and you have got a procal which is positive now.
Yes, sir. If you see the trend of procal elevation, sir, the first elevation will be with the bacterial, followed by viral, followed by the fungal, sir. I would like to rate in 1, 2, 3 bacterial, viral, and fungal as in that rate, sir. Fungal, it might.
I give you a 10. 3.2 day 1, day 3 it is 5.2, day 7 it is 7.2. So what will you think?
I would like to use the fungal biomarkers, sir, more than.
So what does it ultimately? What message? What does it ultimately tell you?
Procal is an increasing trend, sir.
That is fine. So what is it? That means what does it tell you? What does procal positive mean? That's what me and Kanwal are asking.
Infection, possibility of infection.
Infection. You have got a urine routine which is showing pus cells, na?
Yes, sir.
Does it mean only UTI or complicated with sepsis?
Complicated with sepsis.
And how does it help you in the further treatment? That is fine. You see the trend. That is fine. Can it help you to distinguish bacterial versus viral versus fungal?
Not really, sir. Not really.
Will you suspect a fungal infection in this? Can it be a fungal UTI? He's a diabetic.
Yes, sir. The possibility is there, sir. Diabetes, but
possibility, na?
Possibility, yes, sir. Definitely, sir. Possibility is there, sir. But I would like to see the response to my initial therapy, sir. If he's not responding to my initial therapy, uncontrolled diabetic, possibility of fungal sepsis, still I would like to keep
should at least have a thought in mind.
Yes, sir.
Keep that in mind. Yeah. Okay, go on.
Definitely.
Talk about the lab. Talk about the lab.
Yes, sir. So I would like to follow with the data once again. So this was
go back.
Go slow.
No, sir. I would like to say day 1 labs only.
Okay, day 1 labs. Anything beyond this? Any value, other value which will be important to you?
Yes.
What are the electrolytes? What are the potassium values?
What are the electrolytes?
His electrolytes were within normal ranges. Sodium was around 138, potassium was 5.2, and chlorides were 101, ma'am, on presentation.
And what was the blood urea?
Which one, ma'am? Blood urea. Sorry, urea was 60, ma'am, 64.
You have not shown that. That is a very important.
All the investigations should be here. We have to mention it.
Sorry.
And what is the urine routine microscopy?
CUE was suggestive of plenty of pus cells with bacteria present, sir.
Where is the urine report? A basic urine report. Basic urine report.
Which we can get.
Culture. What you're showing on the right is a culture antibiogram. Basic urine, what did it show? How much was the proteinuria?
He was having 1+ proteinuria, sir.
So how will you define proteinuria? What is microalbuminuria and how will you distinguish it?
If the proteinuria is less than 500 mg or if the proteinuria is more than 3 grams,
what is microalbuminuria is above 20. That's the micro test which is positive.
Yes.
But if it's above 3 grams, it goes into a nephrotic zone. Na?
Yes, sir.
So are you thinking of a nephrotic? That's why a basic urine report has to be there. Na?
Many things which we can directly look at from the urine routine.
Yeah, because then RBCs, whether there is RBCs, whether they are casts, whether they are crystals, sometimes you can see acute pyelonephritis, acute kidney injury, you can see hyaline cast can also be seen.
Yes, sir.
These are simple, basic things. These are important as a part of case presentation. I admit that we don't give that importance in the practical perspective. I agree, but once you're presenting a case, it is very important, and you should know as an exam going student, you should know the correlation of the urine routine with the current case scenario. You agree, Kanwal?
Yes, sir. This is the most important aspect actually.
Yeah, absolutely.
Urine routine conveys us so many things which we actually miss down all the time in our clinical practice.
I'm actually put only the ones which were significant. Yeah. His nitrate and leukocyte test tests were negative, ma'am, but he had bacteria present with plenty of pus cells. His pH, his specific gravity, all were within normal limits. Only the one significant I just mentioned.
What is the normal pH?
4 to 8, ma'am. It's slightly acidic. 4 to 8.
4.82. Okay.
Yeah.
And what is the specific gravity?
1.0 1.20 to 1.005 to 1.20, ma'am. Anything less than that or no?
And what is the creatinine clearance of this patient? You said it's an acute kidney injury, na?
Yes, sir. His creatinine clearance was less than 30, sir. His creatinine was 5.3, sir, on presentation.
How did you calculate it? You calculated it on the app or the lab gives you?
Calculated on the
app. You use the iPhone app to calculate it, or you did it on your own, or your lab itself tells you the creatinine clearance?
No, sir. We have done it, sir.
You have done it. So how did you get it?
Based on the creatinine clearance, 140 minus age into body weight 10 kgs, ideal body weight, divided by serum creatinine into 72.
So the Cockcroft equation.
Cockcroft equation we have used.
Okay. Fine.
I think Shravani can also participate. She is also there, I think, sir.
Who?
Sodhi and Subhas, we can also.
Pardon, sorry, Venkat, I didn't hear you.
Yeah, sir. We have two students, Dinesh and Shravani.
I think
there are two cases or the one first
one
case?
Case only.
Yes, I think, and both of them can participate. We
Okay,
can ask both.
okay. So Dr. Shravani, you can introduce yourself and you can also be a part of it. I'm sorry, I thought there are two different cases by two different students. No problem.
Unmute yourself, Shravani.
Achha, now before we involve Shravani, were you really involved in the management of this case?
Yes, sir. Both of us are working at the same hospital, sir.
Achha, otherwise, we ask her questions and they to it doesn't.
No, sir, both belongs to Srinivas Samvedan's hospital, Viranchi. Both of them are.
That is fine. I just thought that both are from the same unit, then it's fine. I mean, they must have seen the patient.
Yes,
that's more important. Rather than just directly answering questions.
No, sir. No, sir.
Yeah, okay. So, what is the ABG?
Sir, his presenting ABG's pH was 7.23, sir, with PCO of 35.3, and bicarb, standard bicarb was 15.2, sir. It was suggestive of acidosis and metabolic acidosis. We have seen for the Winter's formula for appropriate compensation, sir. PCO got appropriately compensated, and anionic gap we have calculated, sir. And for the albumin also we have done the changes, sir. It is suggestive of high anionic gap, sir. Delta ratio also we calculated, sir, suggestive of pure high anionic gap metabolic acidosis. And delta gap ratio was 1.2, sir, suggestive of pure high anionic gap metabolic acidosis, sir. This was presented ABG, sir, today. Yeah.
And what are the causes of high anion gap metabolic?
Sir, in this patient, per se, sir, uremia could be the cause, sir. Second thing, drug-induced, he's on metformin, sir. That also could be one of the cause, sir. Third thing, sir, patient he's having been starving, sir, for the past 2-3 days. His food, food intake has been low, sir. Could be in starvation. Ketoacidosis also likely possibility, sir. These are 1, 2, 3, sir. Uremia, metformin induced, third thing, starvation, ketoacidosis for high anionic.
Another simple question, what you said, that he's been taking diclofenac for the vomiting, right? For the pain.
Yes, sir.
At the start you said.
Yes, sir.
Do you think this acute kidney injury is mainly NaCID induced or it is purely infection induced?
Sir, could be multifactorial, sir. Could be multifactorial. Patient might be having an
How will you distinguish it? Again, what Kanwal said, the most important test, what you have missed.
Yes, sir. So the mainly, sir, whatever this NSAIDs or the sepsis, sir, sepsis initially it can be pre-renal. If not corrected in the initial stages, it can go into the renal cause of AKI. Whereas this diclofenac induced AKI also is predominantly, it's a pre-renal AKI, sir. Coming to the
pre-renal and renal from the urine.
Yes, sir. Based on the urine analysis, sir. If it is a renal AKI, sir, the kidney capability of concentrating capability will be lost.
Tell me one test. You tell me one test which tells you renal or pre-renal.
Sir, in CUE, sir, specific gravity of the urine is one.
Just one test. It's urinary spot sodium, less than 20 or above 20.
Yes, sir. Yes, sir.
If it's less than 20, it is pre-renal. If it's above, then it's renal.
Renal, yes, sir. Yes.
So that's important. Who sees for specific gravity and all, especially in these things? This is one important diagnostic feature.
Yes.
Anything to add, Kanwal?
So what are the other factors in your patient? What are the other risk factors for
he is also on telmisartan, ma'am. Yes. So that also would have been likely etiology, ma'am. That's what multifact. So he was
1, 2, 3, 4.
1, 2, 3, 4. Infection, diclofenac, and telmisartan, ma'am. Yes, 1, 2, 3 causes. Sir.
Anything else, Dr. Shravani?
And ma'am, I would like to he was having decreased intake, ma'am. Decreased hypovolemia also could have been, ma'am, even though his MAP is maintaining, body might be compensating to maintain the MAP.
Anything else? Inadequate intake, you're saying, like patient is hypovolemic.
Hypovolemic.
Anything else?
Anything obstruction, ma'am. Obstruction also, because BPH, elderly male, prostate, should rule out obstruction.
Patient is a diabetic.
Diabetic nephropathy, as already patient had
that again,
microvascular changes are already there. Neuropathy is there. He had neuropathy was there. Peripheral neuropathy association.
Diabetic on metformin, telmisartan.
Yes, ma'am.
NSAIDs in like last 2 days. All these factors they do.
Yes, ma'am.
Right. Okay. And I think. So anything else? I think we move ahead. Let's just go. What else?
So when he presented to us, sir, so we have sent all this investigations that I have mentioned, and we have done this ABG. So he was having this pure high iron gap metabolic acidosis as a pass to, and after sending appropriate blood and urine. After starting blood and urine culture, sir, we have started him on appropriate broad spectrum antibiotics. So we have put him on piperacillin tazobactam loading dose. We have given him in the ER, and after shifting to the ICU, sir, we have assessed for his volume status, because he was oliguric. After ruling out obstruction, we have ruled out obstruction, sir. So
how did you make your choice of antibiotic? You started with
ma'am.
What basis?
Actually, this is an this is a complicated UTI, ma'am. So complicated UTI in a patient who background had an uncontrolled diabetes, ma'am. So as per the guidelines, I would like the recommendations for a complicated UTI, that's pyelonephritis. The first line agents are a third generation or fourth generation cephalosporins, or broad spectrum penicillins like uridopenicillins like piperacillin tazobactam. In this case, if there is resistance, if this is a community acquired infection is what having, ma'am. So yes, ma'am, this would be like BLBLS or extended spectrum penicillins like piperacillin tazobactam would be my first line agents.
Okay. And how was your patient on presentation, hemodynamically? And
he was actually he was tachycardic, ma'am. Hemodynamically he was stable, but his urine output, ma'am, after placing a Foley's cath, his urine output was only 30 ml, ma'am. So he was only 30 ml after placing Foley's. So yeah.
In which stage of AKI your patient will be?
Based on creatinine, ma'am, highest stage as per the classification, he belongs to stage 3 AKI as per the KDIGO classification, ma'am.
Okay.
His creatinine was more than 4.
Okay, creatinine was more than 4. Right.
Yes.
Okay. I think Dr. Shravani, you are not audible at all. Just continue. Okay, so have these investigations. Anything else you want to
So as the patient was oliguric after fluid obstruction, ma'am, investigations, ma'am. Sorry.
Yeah, you just go ahead.
Yeah, so I wanted to give a fluid challenge to the patient, ma'am, as the patient was oliguric. So prior to that, I have checked his volume status, ma'am, volume status of the patient.
Put in the line.
How did?
Sorry, sir.
Have you put in the central line?
No, sir. I have secured two peripheral IV cannulas. That's it. I didn't secure any IV. Sorry, I didn't secure any central lines.
Okay. So how will you optimize the fluids?
So first thing I would like to see is the fluid. He's not presented to us in any acute circulatory failure, ma'am. So I would like to see his volume status of the patient, ma'am. So what we have done, we have checked his IVC, ma'am. IVC collapsibility index. Along with that, I have even seen for his VTI variation, ma'am. VTI variation and even the left ventricular end diastolic area calculation. Now we have merged all these three and we have given a fluid challenge of about 2 liters fluids we have given, ma'am. Following which started developing B-lane, so we didn't go beyond it, ma'am. But even after giving 2 liters of fluid, patient was still oliguric, ma'am. His urine output didn't improve. So at that moment, we have given him Lasix, ma'am. We have given a 1 mg per kg body weight of Lasix. And we have waited for about 2 hours. But even after that, his urine output, hardly he has poured around 50 to 80 ml in for the next 2 hours, ma'am. So that was the moment we have repeated in ABG and we have seen the acidosis was persistent. We have consulted the nephrologist and we have decided to put him on RRT, ma'am. And we have initiated renal replacement therapy after securing an IJV double lumen HD sheet, and we have put him on actually SLED, ma'am. SLED we have initiated.
Suppose Dinesh, if you have put in a line,
yes, sir.
then if the CVP is 0.
Which one, sir?
Sorry, you have put in the line, you just saw the IVC, if the CVP is 0.
Yes, sir.
How would you optimize the fluids and which fluids would you like to give him?
Sir,
now that you have just stated, you have just taken the patient on dialysis.
Yes,
have
sir.
you ensured the fluid optimization first?
Yes, sir. That's what, sir. We have given about 2 liters of fluid, sir. After that, patient started developing B profile.
CVP, yeah, Kanwal, go on.
Sir, please.
No, my question was, he is given 2 liters of fluid, is not passed to urine. You have given a Lasix challenge also. He's still not passed urine. You said you just put the patient on a renal replacement therapy. Have you ensured that the CVP is adequate, patient is adequately filled, especially in sepsis? Do you think CVP is important in this patient?
Yes, sir. More than a single value, I would like to see the trend of CVP, sir. And
first, you have not put in a CVP only. Then how can you see the trend of CVP?
We have
put in a CVP first, na?
We have seen
the trend.
We have seen that IVC correlation. Sir.
Okay, IVC collapsibility is there. Yeah, Kanwal, go on.
Sir, do you think only IVC collapsibility will ensure that your patient is volume?
No, ma'am, because the patient is tachypneic, it might be giving me a falsely, false positivity test or will be high. So I would like to merge or combine with other dynamic hemodynamic variables like that. In this patient, a non-invasive variable, I would like to check like VTI variation with the respiration, and then even a left ventricular end diastolic area, how are the ventricles, how are they getting contractile, any hypercontractility is seen, kissing ventricles. All this will point out more of an hypovolemic patient, ma'am. Not one just parameter, ma'am. 1, 2, or 3 parameters I would like to combine and then come to a conclusion regarding the fluid status, ma'am.
Okay. Have you listened about the AKI care bundle?
Yes, ma'am. AKI care bundle. Yes, ma'am. I have. In that.
So what it tells you about?
Yes, ma'am. AKI bundle, ma'am, mainly they have emphasized on avoiding the precipitating factors, like avoid like in a high risk populations. If the patient is having an underlying diabetes and hypertension or prior CAD, these are the high risk population where ideally we should avoid nephrotoxic agents. We should check for the fluid status of the patient, maintain euvolemia, avoid nephrotoxic agents. Then avoid again contrast agents in them.
Most basic thing the AKI bundle talks about is the optimization of hemodynamics.
Yes,
and
Yes, ma'am.
So if you have not optimized your volume status itself, right? So going beyond that, I think that this is what Dr. Subhal wanted to highlight, that just giving fluid and giving a diuretic.
Okay. Okay, ma'am.
Just started with the renal replacement therapy. Is it?
Yes,
right?
ma'am. Yes, ma'am.
Is it the best possible
Yeah.
option available with you, or you can just go ahead with more basic things rather than going in for the invasive renal replacement therapy? Because then therein we'll come about like for the early renal replacement therapy or the late.
As you started developing, we were worried about fluid overload statement. That's why we stopped.
But
How did you come to know?
You have seen the end diastolic volume also, na?
Left ventricular end diastolic, yes, sir.
You have seen that. You have seen the echo also.
Yes, sir. Echo
And
and
is also good.
yes, sir. LV is good, sir. No issues. Echo is fine.
Okay. Which fluids will you use in this patient?
So, sorry, sir.
Type of fluids.
Sir, I would like to use a balanced crystalloid, sir. Ideally, plasma light, like ringer lactate or plasma light, that is ringer acetate is I would like to use, sir.
Why no normal saline?
Normal saline, yes, sir. Not anything. Yes, sir. Normal saline also, sir.
Then
up to if I'm planning to use up to 1.5 liters, I would like to monitor chloride levels, sir, and I would like to use, sir, because yes, sir.
Chloride levels, as it is the electrolytes you're going to get, na?
Yes, sir. Yes, sir. I would like to monitor chloride levels, and
the specific advantage of using only balanced crystalloids, that is only to avoid hyperchloremic acidosis. That's
yes,
the only thing.
Yes, sir.
And in the whole part, how will you control the sugars?
So sugar, sir, if any
You said that the sugar levels were 196.
196, sir.
HbA1c on 9.9.
9.9, sir. Yes, sir.
So how have you thought about controlling his sugars?
Sir, actually, his blood sugars, we have started him on insulin infusions, sir. Like following admission to the ICU, 2 consecutive recordings were more than 200, sir. So we have started him on insulin infusions, insulin infusion also, sir.
Okay. How do you initiate the insulin infusion?
So we have given 0.1 unit per kg as a bolus, and following which the same as an infusion we have initiated, sir. Early blood sugars we have checked, and we have targeted about 50 to 75 as our target reduction, and we have continued with insulin infusion, and ongoing fluid status also we have been assessing, and we gave fluid as boluses, are not as by any maintenance. We have given continued fluid up to 2 liters we have given, sir, and continued with the insulin infusion, sir.
Okay. Go on. Yeah,
What was your sugar target?
Sugar target, ma'am, actually less than 200, ma'am, but early, yes, ma'am, less than 200 is our target, not beyond it.
Less than 200.
Yes.
Have you read about any guidelines where how sugar should be kept?
The NICE guidelines, sir.
NICE guidelines is the NICE and the intensive insulin.
140.
Sorry.
It should be kept reasonably well under control, 150 to 170, and see that.
Yes, sir. In case of
the target, what you should at least have it.
Yes, sir.
Even the ISCCM AKI guidelines say that we should have below 180 only.
Yeah.
Sugar should not be the target.
Yes,
so this is all what comes in the AKI care bundle, what I was talking about, like your optimization of hemodynamics,
sugars and
sugar control, vasopressor
control. Right.
and your optimization of this blood pressure.
Yes.
Pressure target, like your patient is a hypertensive.
Yes, ma'am.
What
So blood pressure target, ma'am, as patient is a chronic hypertensive, like to maintain MAP maybe around 80 to 85, ma'am, as per the sepsis time trial evidence. The ones who are chronically hypertensive, the target MAP being maintained at 80-85 didn't have any mortality benefit, but the need of RRT or the patient needing RRT has been comparable with the ones who are maintained at 65. So yeah, yes, ma'am.
So you distinguish between a hypertensive patient and non-hypertensive patients. So you have separate targets for each.
Yes, sir. So basically, the ones who the ones who are hypertensive, sir, their auto regulation would have been already shifted onto the right side of this thing, sir. Like the perfusion pressures would be on higher side to maintain the organ perfusion. So trying to maintain a lower map, that is anything less than 80 and all, they can have decreased organ perfusion, sir. So we have to maintain and higher targets for them, sir. Because already their map would have been on higher side. And yes, sir.
Achha. Did you continue telmisartan in him?
No, sir. No, sir. We have stopped it, sir. We have not.
No.
Then how did you control the blood pressure?
His blood pressures were actually within normal limits, sir. Like he didn't have any elevated blood pressures and all, sir.
And in case if his blood pressure was increasing to 170, 100, 190 to 100, how would you like to control it?
In that scenario, sir, I would like to start him on an IV NTG or labetalol, sir. In that scenario, if it is, yes, sir.
Hello?
Yes, sir. Either a labetalol or an NTG, I would like to use, sir.
Hello.
And
Okay. What are you oral tablets?
which one, sir?
Oral tablets.
Oral tablets, either I would like to definitely avoid an ACRP, sir. If there are no contraindications, a long-acting beta blockers, sir. Beta blockers or calcium channel blockers would be my second and third line of antihypertensives of choice, sir. Oral long-acting, I would like to use metoprolol 25 mg BD, sir, up to 50 mg. I would like to use, sir, or calcium channel blockers like
Okay. Now, Dr. Shravani madam, are you available?
Yes, I'm available. There is some issue with my device, sir. I rejoined. Yes, sir.
You know the entire case that it's
Hello.
acute pyelonephritis.
Yes, sir. Yes, sir.
Kidney injury. We have optimized the fluids. He has started antibiotics
Yes,
from that perspective. So what are your thoughts and how will you plan
Yes,
the
sir.
antibiotic protocol in this case? What are your thoughts about planning of antibiotics? Do you agree with what your colleague has said, or do you have any other different thoughts and ideas in your mind? It can be different.
Yes, sir. I agree with him because this patient is from a community with no previous hospital admission in last 90 days. And it is a community acquired UTI, most probably E. coli. I go with either BLBI or third generation cephalosporins combinations initially. And based on the culture sensitivity, I will go further as any escalation of antibiotics, sir.
Okay. Yeah, Kanwal, go on.
Yes. Okay. One thing I wanted to beyond all the investigations, do the routine biomarkers help in AKI diagnosis? What is the problem with them?
Hello, ma'am. Biomarkers role. Yes, ma'am. If you're going by the conventional markers, ma'am, either by the urine output criteria or the creatinine criteria, we require any significant drop in the GFR. That is, we require a GFR drop of at least up to 60 ml, sir, for the creatinine to increase. So in that scenario, the renal reserve, which even though if the patient recovers from the AKI, in future, if the patient develops a secondary insult, the renal reserve, which was supposed to be preserved for them, is not already gone. So all our target is to identify the patient in the subclinical stage so that whatever the minimal changes that are there would be able to be picked up by this biomarkers. So which doesn't require any significant drop in GFR also. So early identification of AKI in the subclinical stages itself would be able to identify, and even at risk factor patient also the biomarkers would be useful, ma'am, to pick up the AKI likely cause. I mean AKI likely probability in the subclinical.
Biomarkers which you would like to use?
Commercially
Cystatin
used.
C, NGAL. Hello.
Hello. Yes.
Cystatin C and NGAL, ma'am.
Okay. Anything you want to add, Dr. Dinesh?
Yes, ma'am. Nephrocheck proteins, ma'am. TIMP and IGF-BP7 also. They are FDA approved biomarkers, ma'am. As per the.
So how much time they take?
Sorry, ma'am.
Is it available?
In India, not sure ma'am, whether they are available.
Yes, it is available.
Okay.
And we can get the results in an hour or so. They just recently become available in the settings, right? So yes, there is a role. Even the ADQS says that along with clinical scenario, you have the biomarkers
combine the biomarkers.
Yes. Although if you say that the biomarkers, they do not actually, the cutoffs are not clear.
Yes,
right?
ma'am.
Not know which one to use. And, tell me the difference. Like, you would like to use the urinary biomarkers or the serum biomarkers? Which are
not one biomarker as such, ma'am. A combination of biomarkers would help for an interpretation. Why combination helps us to know what exactly is it a pre-renal component or renal component? If so, what could be the etiology? So more combination biomarkers will help us to for the prognostication purpose to see whether the patient is responding to a therapy, and even if the patient might probably land in need of RRT or renal replacement therapy. Yes.
Dr. Shravani?
Yes, ma'am.
Please. I think Shravani has a.
Yes, ma'am. I'm able to hear, ma'am. Hello.
Okay.
Hello. Hello.
Thank sir.
Yeah, go on, Kanwal. I'm listening. I'm here.
Okay, sir. So,
only thing, Shravani's connection, I think, is not.
Yes, sir. So I think we continue with Dr. Dinesh only.
Yeah, no issues.
So we have all these investigations available, right? Now, anything else you want to? Any other?
Yes, ma'am. As I'm suspecting pyelonephritis, ma'am, not initially I would like to get a CT, ma'am. If the patient is not responding to my medical management, like if the patient, actually in our patient, ma'am, on day 1 of presentation, we started him on this broad spectrum appropriate, that is piperacillin tazobactam, and we put him on sled for 6 hours, ma'am. Post one session of sled, his acidosis has improved, ma'am. But patient's temperatures were persistent.
Just a minute, Dr. Dinesh. What were the clear-cut indications of starting your patient on renal therapy for this patient?
He was oliguric, and there was persistent metabolic acidosis. Even after optimization of the volume status and giving him a fluid challenge and then diuretic challenge, his urine output didn't improve, ma'am. So for the
when did you repeat the blood gas?
After 4 hours of presentation, ma'am. So after coming, we have over 2 hours, we have given about 2 liters, and then a diuretic challenge of over. And we have given and waited for 2 hours, ma'am. So totally about 4 hours we have waited for after coming to the ICU, and then we have taken the call of initiating him on RRT, that is sled, ma'am, after discussing with the nephrologist, ma'am.
Okay, so you involve your nephrologist along with.
Yes, ma'am.
That is not there. Okay. Okay, so you say that your patient had non-improving metabolic acidosis.
Yes, ma'am. Yes, ma'am.
Right. So you started with the renal replacement therapy.
So even after one session of sled, ma'am, his acidosis has improved, but his temperature spikes were persistent, and the following next day his counts were also an increasing trend. So that was the moment we have taken a neurologist opinion, and we have got an CT-KUB done, ma'am, which was suggestive of. If you see, ma'am, this here in the right side kidney, we can see kidney was bulky, ma'am, and we can see an hypodense lesions seen in the kidney, ma'am. So it was suggestive of pyelonephritis, and even in the coronal cuts, he was having hydroureteronephrosis, ma'am, with perinephric fat stranding. Was more suggestive of radiological evidence, was suggestive of pyelonephritis, ma'am. So urologist has given his opinion of putting an TJ stent, ma'am. So we have taken him after optimizing his blood gas status and giving him another repeat dose of antibiotic. We have shifted him to the OT, ma'am. It was done under local, ma'am. TJ stenting was done actually bilateral, ma'am, because urologist, after putting ureteroscopy, has noted pus being coming out from the both ureter. So he has put an bilateral TJ stent, and he was shifted out of OT to the ICU in a hemodynamically stable state, ma'am. And yes, ma'am. Post TJ stenting, his urine output has improved, ma'am, in this patient.
Okay. So how did you decide the drug dosing in your
drug dosing,
was on
ma'am?
RRT?
Yes, ma'am. As the patient was on RRT, ma'am, and the patient was having sepsis. So, sepsis. If you see the pharmacokinetic principles, ma'am, mainly the four principles, that is absorption, distribution, metabolism, and excretion. Both his distribution and excretion. Volume of distribution has been increased. It's an hydrophilic group of drug, so his volume of distribution is increased. So, the loading doses we have given as per the standard dose, ma'am. Following that, we have calculated as per the creatinine clearance, ma'am. But this patient, we have even after finishing SLED, we have repeated another dosage, ma'am, and we have given it as a prolonged infusion, ma'am. Over 3 hours, we have given this as an infusion. Yes, ma'am.
It's always important to load the drug post.
Yes, ma'am. Because mainly this hydrophilic group of drugs are time-dependent killing, ma'am. So all we have to maintain is above the MIC, at least for the 40% duration of the time between the two interval dosages. We have to give it for the 40% of the time as an infusion, as a prolonged infusion. So that's how we have calculated, ma'am.
Okay, so you got the patient DJ stenting done. Okay, and post stenting,
his urine output has improved, and following that he was hemodynamically stable, but total duration of stay in the ICU was for 5 days. In the ward he stayed for 2 days. Later that he got discharged, ma'am. But during the stay of patient in the hospital, ma'am, totally he underwent 3 sessions of dialysis, ma'am. He underwent first session was a SLED, ma'am. Later on the next 2 sessions he was put on IHT, ma'am. Actually for the uremia, as per the nephrologist, they have done dialysis, ma'am. But his creatinine was actually improving, ma'am, because it was in decreasing trend, and we have, prior to the discharge, he was assured, and HD sheet was removed, and he was put on levoflox, and we have advised him to take for 7 days, and we have sent him back home, and asked to advise to follow up the OP with.
Is there any advantage of shifting from SLED to HD? As far as the solute clearance, as far as the...
Yes, sir, definitely, sir. The solute clearance is better with an IHT as compared with the SLED, sir. Initially, we have used SLED in this patient, thinking patient might have intradialytic hypotension risk, as it was at first session of dialysis. We put him on SLED, sir. Ideally, for better solute clearance, IHT is better as compared to SLED, sir. The first SLED that we have done only plain SLED, sir, without any VF for 6 hours, sir. Anyhow, after that, his urine output started improving. He had IHT. Yes, sir.
So from the intensive perspective, which type of dialysis RRT is the best for him, do you think?
If the patient, Shravani.
Yeah, Kanwal, go on, please.
Shravani wants to say. I'm not interrupting.
Yes, Shravani.
Most of the it's a CRRT, sir, for fluid management and solute clearance and maintenance of acidosis clearance. Also, CRRT is the best for the ICU patients who are hemodynamically unstable.
Any other benefit of CRRT for your patients specifically?
Fluid and nutrition management and slow solute clearance and hemodynamical maintenance, and patients who are on acute renal liver failure also, and also those with raised ICP. We don't want a rapid fluid osmolarship, so that CRRT is the best option for the ICU patient.
The hemofiltration will also remove the inflammatory mediators.
Yes, ma'am.
The septic shock,
Both.
but yes, it can be a beneficial thing for your patient. So, and on what basis actually you decide the modality of RRT?
Pertaining to ICU patients, one is the hemodynamic status of the patient, ma'am.
Okay. What else?
And
one is the
hemodynamic.
What else? Dr. Dinesh?
Any other associated organ dysfunction, like in case of an acute liver injury, the modality again varies where and associated with any risk of any head injury and all. The modality definitely matters because we don't want any rapid fluid shifts and even these osmolar shifts also we don't want, where with gradual removal of these solutes and even pertaining to the renal recovery also, ma'am, as they mimic the normal kidney function. This hybrid techniques like this SLED or CRRT would be an ideal choices in ICU population with hypotension and other scenarios as expected. Any liver injury.
Are there any studies which say that one modality is better over?
Actually, yes, ma'am. I remember reading that this meta-analysis, ma'am, which has come with like that all like even though CRRT has a slight benefit over SLED in pertaining to the renal recovery, but not mortality wise. Definitely no one modality, even IHD or CRRT or SLED were not. They have benefit, but in pertaining to the renal recovery, definitely CRRT slightly has benefit over SLED.
I think Subhal sir can comment. Sir?
No. Hello. I think you are a better person to comment on this.
No, sir. I just wanted to know because in my...
Yeah, absolutely. Yeah.
No, sir. I think, sir, there is no benefit of one modality over as far even for the renal recovery is concerned. None of the, I'm not, I'll also have to go back and read this, if at all there's a meta-analysis available. But none of those modalities has been shown any benefit over the other. But
yeah, that much I know, not much benefit.
Yes. And one important thing is what you want to remove.
Yeah, yes, ma'am.
Foremost thing which will decide the modality of RRT.
Yes.
Like
Yes.
what you want to remove. You want to remove the small molecules or the middle molecules or the larger molecules.
Yes.
So to remove the electrolytes, potassium, uric, even lithium for the poisonings, the IHT is a better modality.
IHT. Yes, ma'am.
So you must know like what is your target, like what we want to remove. And then beyond that, we have all talked about the hemodynamic stability, what is the patient hemodynamic status, then the available facilities. Like if at all you have the CRRT available or you want to utilize the normal IHT machine for your SLED, because you can utilize that, right? And then I think obviously the expertise is there. So these are all the important things which decide the modality. And as sir was asking, like any benefit of shifting from SLED to IHT?
That's what, ma'am. Later on, we were been targeting predominantly the solute clearance. Only for the azotemia purpose, he underwent dialysis. So, yeah.
You said hemodialysis clears those solutes much more better.
Yes, sir. IHD, the solute clearance is better with IHD as compared. The urea clearance is better with the IHD as compared with the SLED.
Right.
Okay, and what about the nutrition part?
Yes, ma'am. Nutrition, ma'am. First thing, what I would like to see, as this patient was on renal replacement therapy, I would like to see whether the patient is having underlying any risk factor for nutrition, ma'am. Based on the scoring system like NRS and the Nutric scoring system, I would like to see are there any risk factors for nutritional deficiency. Following which the
when do you start for? My questions are very clear. When do you start nutrition? What is your plan?
Early nutrition, ma'am. Either if the patient is accepting orally, we will give him orally. If not in a state accept oral, I would like to prefer an enteral nutrition via an rice tube feeds, ma'am. I would like to calculate the calories and proteins, ma'am. Calories either based on the ideal body weight of 25 to 30 ml, 25 to 30 kilocalories per kg body weight. As the patient is on RRT, I would like to give proteins up to 2 grams, ma'am. Calories up to 30 kilocalories and proteins up to 2 grams. I would like to go, ma'am.
Patient who is not on RRT?
Not an RRT, I would like to give him protein of up to 1 to 1.5 grams or and calories of up to 25 kilocalories, 25 to 30.
Is there any difference between different modalities of RRT?
Yes, ma'am, definitely, ma'am. The protein loss is highest with the CRRT, ma'am. So patient has to be on high protein diet, definitely has to be high protein diet, because along with the proteins, he'll be losing a lot of amino acids, these vitamins, all this will be lost in CRRT along with the electrolytes. So all this has to be measured. Measuring, we will do mainly the potassium, calcium, and magnesium and all. We have to supplement him with this, ma'am. Yes.
Can you just give 2 grams of proteins per kg body to your patient?
Sorry,
You're
ma'am.
saying that you want to give 2 grams per kg.
Yes, ma'am.
So are you able to give? What are the
in this patient, ma'am?
Yes, you're saying that patient is on RRT, so you'll give 2 grams per kg protein.
Yes, ma'am. Yes, ma'am. We have given 2 grams.
The patients do tolerate?
Yes, ma'am. Tolerated, ma'am.
So how you're giving? Supposedly you want to give the enteral feed. Then you will have to give the volume also. Your patient is oliguric, or supposedly your patient is anuric.
Okay, ma'am. Ma'am, I actually had interruption of your.
I'm asking you, like you're saying you want to get 2 grams per kg protein to your.
Yes, ma'am.
Right? This is what you have told?
Yes,
so going to give. Patient is on enteral feed. Nasogastric feed देनी है आपको. So up 2 gram protein, do you think the patients tolerate 2 gram per kg? Will you give? कर लेते हैं tolerate?
2 grams is too high.
Okay.
Right, even the guidelines say up to 1.7 grams per kg, 1.5 to 1.7 grams per kg is good enough, because there are always issues. You want to limit the volume also for these patients.
Okay.
If you talk about the hypercaloric feeds,
Yeah.
I personally feel, in my experience, I think they are not very nicely tolerated by the patients. So giving so high, yes, the literature does say up to 2 grams per kg proteins, but usually, practically speaking, you are hardly able to give 2 grams per kg protein to the patients on RRT. So even up to, you give, if you're able to give 1.5 to 1.7 grams per kg, it is good enough, right? Because as you were saying, that there's lots of loss of the amino acids, loss of the vitamins, trace elements, they are all lost. So we should be very much concerned about, yes, you need not restrict the proteins in your patients who are on RRT, or even with AKI also you give up to 1.5 grams per kg protein.
Yeah.
Okay. Subhal sir?
Yeah, I'm listening. You can go on. No, you can go on the case further.
I think, sir, we are done with the case.
Right. Actually, we have
Dinesh?
Hello? Dinesh?
Yes, ma'am. Done.
Can you go on? Can you go on further? Can you move on? Can you move on? Next slide. So you said you put a stenting and find the patient was shifted out.
Yes, sir.
They have discharged, sir. They have discharged the patient.
Oh, they have discharged the patient on day
Yes,
6
sir.
with a create of 3.
Yes, sir.
Fine. So actually, Dinesh, you have done quite well.
Thank you, sir.
Yeah. Any other questions you would like to have?
I think the audience can also, all of you can put your questions in the chat box if at all you want. You have some queries. Okay, I think, sir, we can just talk about the anticoagulation part also for the ICU patients once we talk about the renal replacement therapy. So what anticoagulant did you give for your patient?
No, we didn't give any anticoagulation to the patient.
So how did you manage?
It was just a 6 hours slate which was done, ma'am. So we heparin free we have given, ma'am.
Heparin free, I get it. You did not give anticoagulation, but something you have to do.
Sorry, ma'am. How did we?
Something you have to do still.
Okay. A systemic anticoagulation with unfractionated heparin. If there is no coagulopathy, we can use, ma'am. Unfractionated heparin we can give at 25 to 30 units per kg as a bolus, and maintenance we can give about 5 units per 5 units per kg as maintenance, monitoring APTT of around 1.5 to 1.9 times from the baseline, ma'am. That is one thing. Either we can give an unfractionated heparin or enox enoxaparin 1 mg per kg BD dose we can give, ma'am. If there is risk factor, if for heparin-induced thrombocytopenia, we can prefer other direct thrombin inhibitors like bivalirudin, argatrobil, but not routinely used. So, or regional anticoagulation, ma'am. In regional anticoagulation, that is mainly for the CRRT. If the patient is on CRRT, either we can give a regional anticoagulation of heparin protamine, where we give pre-pump heparin, and post-pump we give protamine, ma'am. For every 100 units of heparin, 1 mg of protamine we give, or we can give that's citrate anticoagulation, ma'am, where prior to that we measure the patient's total calcium and the ionized calcium. So pre-pump we give citrate of about 3 millimoles per liter. It is given as pre-pump. Post-pump we measure this ionized calcium and we supplement the patient with calcium. Target ionized calcium in order to maintain circuit free from getting clotting is 0.2 to 0.4 ma'am. Or either we can go with the saline flushes every hour 100 ml. And the same thing, whatever we are giving saline flushes, we can remove in the effluent as an ultra filtrate. We can put it and remove it, ma'am. So
issues with regional,
yes, ma'am. The main issues are one, citrate mainly it's getting metabolized in the liver. So if the amount of citrate is getting too much, getting accumulated, that is the metabolism is too much than the clearance. I mean the accumulation is faster, like citrate toxicity. Citrate toxicity, as said, it produces metabolic alkalosis and hypernatremia. It can produce bleeding disorders. It can produce hypocalcemia. These are some of the complications like associated with citrate toxicity. Bleeding complications, citrate toxicity like metabolic alkalosis and hypernatremia and hypocalcemia. These are some of the risk factors with the regional citrate anticoagulation. And as such, it is very costly, ma'am, to use, and we have to be very vigilant in monitoring this ionized calcium with that to that of total serum calcium, and make sure that these ionized calciums are being maintained in the circuit, and we have to supplement calcium levels. So regularly we have to keep checking fourth hourly and supplement this. Yes, ma'am.
So if at all you are not giving any anticoagulation like you did in your case,
saline flush we can.
Saline flush. So this was what I was asking you. Like, did you do anything else?
Saline flush.
Flushes, and that saline which is being flushed, you have to be very vigilant about that.
Yes,
we usually forget.
Yes, ma'am.
We start with slate, we give supposedly 500 mils of that saline flush. Yeah. We tend to forget that. So we must be very vigilant about
yes, ma'am. Yes.
Right?
Yes, ma'am.
Okay. And you gave only 3 sessions of hemodialysis, right?
Actually,
and one slate.
Yes, ma'am.
So then you discharge your patient on day 7 with a creatinine of
3.2, ma'am.
3.2.
3 was 3, ma'am, at the time of discharge.
So did you plan? Did your nephrologist for you?
Yes, ma'am. We told the patient to follow up with the nephrologist and the nephrologist, ma'am, in the OP.
So, okay. If we routine about, when do you wean from RRT?
Wean from the RRT, ma'am, first for whatever the indication that we have started the patient, ma'am, that should have settled. In this scenario, basically we have started the patient on slate because of his 2 main indications, that is oliguria with persistent metabolic acidosis. So if my metabolic acidosis has closed in, and the 2 main primary indications that why we have done, ma'am, that is oliguria and metabolic acidosis. So once our primary intentions for what we have initiated has settled, we can start weaning the patient, ma'am, following which we can put him on intermittent hemodialysis if the patient is able to tolerate for azotemia purpose, and wean him in that manner, ma'am. CRRT is led to IHD.
At what amount of like urine you will think about, like you can wean your patient? Patient is oliguric, still around 20 mils of.
I'm not sure with the urine output criteria for de-escalation. Weaning.
I'll suggest please do go back and go through the ISCC and AKI guidelines.
Yeah.
Subhal sir is a part of that. Myself too. You must go because you are into the Indian settings, and we have just tried to inculcate what we are practicing.
Okay.
Right?
Okay.
We say that yes, urine output of more than 400 mils per day.
Okay.
We only say, even the best trial and many trials have shown that once the urine output is more than around, they say 400 to 500 mils per day.
Okay.
Then the urinary clearance, creatinine clearance is another thing which you have to always look for. And
Okay.
the important thing, the basic indication for which you had started
Yes, ma'am.
RRT, that has to go off, right?
Yes.
Yeah,
Sir?
actually quite okay. I think we are done.
Is it okay? Right, sir. Anything, I think we have question and answers.
There are just two questions in the chat box. CRRT dose in this patient. In this case, Dr. Reddy madam feels that they should have waited a few more hours for starting off this. But see, honestly speaking, that's an individual perspective. What goes, sometimes early initiation has also shown to be beneficial. It's all ifs and buts, but effectively we have got a good outcome. That's more important for us. Yeah, Dinesh, you want to ask anything? Or you're quite, if there are no questions, then I would hand it over back to Venkat. I thank Kanwal for assisting me, joining me, supporting me, and helping me out through this case. Huh?
Sir, please, we always need your guidance. Just looking at you.
CRRT is mainly your area of domain.
Oh, sir, it's all,
Yeah.
the guidance which works.
So again, I thank Venkat for the warm invitation, and it was really nice presentation, Dinesh.
Thank you, sir.
Very well done, and keep it up.
Thank you. Thank
Convey
you,
my
sir.
regards to Srinivas also.
Definitely, sir.
Yeah.
All the very best, sir. They have the exam, I think, in a week's time.
Next month, ma'am, but dates are not
Next
yet.
month. Okay.
Not yet.
All the very best.
Thank you. Thank you.
All the best.
Thank you, sir.
And all the
Thank
best
you,
to you, Shravani madam also.
Shravani madam couldn't join.
Unfortunately, we couldn't, she could not join. She was on the mobile, I think. So.
She had some network issues, sir.
So here we have a heavy rains, ma'am, actually.
Okay.
There's some network issues going on with them.
Venkat, I thank Yashoda Hospitals for the invitation and hand it over back to Venkat for his closing remarks.
Oh, thank you, sir. Kola sir is also, I think, is not connected. I mean,
Everybody has some network issues.
Network issues, ma'am. I think we can close the session now. We are done with the things, right?
Right.
Thank you so much. Thank you so
Thank you
much.
all, sir.
Thank you very much, and wish all the students all the best. Thank you. Do well. Thank you.
Thank you, Dr. Dinesh, for a wonderful presentation.
Thank you very much. Thank you, Dinesh.
All the very best. Keep your confidence levels very high.
Thank you. Thank you.
Good. It was a nice presentation.
Thank you, sir.
Thank you.